يلا تمام، يعطيكم العافية جميعا. طبعا أنا الدكتور فادي صافي، أخصائي Pulmonary and Critical Care في University of Toledo أوهايو. تشرفنا فيكم جميعا، وإن شاء الله إنه نقدر نبلغ المحاضرة بشكل جيد. ممكن بأي وقت مقاطعتي، أي سؤال أنا مستعد للإجابة. اليوم إن شاء الله we will talk about the approach to lung cancer. أنا طبعاً pulmonologist, I'm not an oncologist، لكن إحنا طبعاً we diagnosed lung cancer، وطبعاً إحنا اللي بنحول الكيس للأونكولوجي. فعشان هيك أنا بدي أعطيكم فكرة كاملة عن كيفية التعامل مع lung cancer from a pulmonary perspective، من ناحية الأخصائي الأمراض الصدرية. هلا هاي المحاضرة معظمها موجهة للريزيدنتس اللي هم يعني senior residents and interns. يعني حاولت إنه هي المحاضرة برضو أنا بعطيها للpulmonary fellows، فشوي المحاضرة يعني بدها تركيز، لكن محاضرة مهمة جدا، وكثير من المعلومات الموجودة في المحاضرة هتكون موجودة في البورد الأمريكي للإنترنال ميديسن، وبعتقد أي بورد حتى ممكن الفلسطيني، وممكن أنت راح تتعرض لللان كانسر. يعني حوالي في البولمونري بورد 10% من الأسئلة راح تكون لان كانسر. تمام. هلا الموضوع شوي شائق ومعقد شوي، لكن أنا راح أحاول قدر الإمكان أخليه سمبل. فبدي أعرف أنتوا عندكم هلا معظم الأودينس internal medicine second year third year، في medical students؟
لا from first year to fourth year.
residents صحيح؟
Yes. medical residents.
وفي medical students كمان؟ تمام. طيب، فأنا هلا learning objective اليوم راح يكون to discuss lung cancer epidemiology and risk factors, and then I will explain the classification and staging of lung cancer، وهي شوي بدها شوية attention. describe الapproach، يوم يجي عندك مريض وعنده solitary pulmonary nodule، how can you manage it. بعدين I will talk about the screening guidelines، وبعدين إن شاء الله we'll do 5 questions. فهلا الانtroduction as you know يعني it's very important. I don't want to go too much into information that you guys find in the internet، بس بدي أعطيكم شوية experience. فال US numbers based on 2019 عندنا every year حوالي 200,000 new cases of lung cancer every year. So that's huge. الإمباكت نحكي عن billions of dollars، نحكي عن lot of deaths, around 140,000 deaths every year in the United States from lung cancer in general. So this is the number 1 cause of killer among all cancers, more than prostate, breast, and colon combined. Okay, so that's why there's a lot of attention about lung cancer. Globally, I don't have the figures in Palestine أو الوطن العربي، unfortunately ما عنديش figures، لكن بعرف globally 1.8 million new cases a year, and most of the cases are from China and India، لأنه في كثير exposure للsmoke وللenvironment، you know, cooking inside houses, other environmental factors, air pollution, all that affect. والsmoking is very high. يعني the prevalence of smoking في United States في أمريكا في السبعينات in the 1970s and 80s was around 40 to 50%. Now it's only 15%. So they work so hard to get the numbers down. طبعا في, you know, as you know, في Middle East, for example, Jordan was like 60%. India and China figures are probably around 40 to 50%. So it's very high. And there is 1.6 million deaths per year. So that's why the disease impact is very high. So the other issue here is the problem as well in the 5-year survival of lung cancer, all stages, I'm talking about stage 1, 2, 3 combined together, is 16 to 18%. So In the 90s, it was around 16, it was around 18%. And for the last 20 years, with the advance of lung cancer screening, we were able to get the figures down to 18%, to 16%. So not much improvement, but it's something, because the 16% reflect a lot of death prevention of around 20,000 patients per year. So that is significant. The other problem we have is that 79% of patients diagnosed with lung cancer, they present with distant metastasis. So around 80% of patients, they present with its stage 4 disease, because that's when they develop the symptoms that come to the physician, such as cough and hoarseness and chest pain. All of those develop, or the paraneoplastic syndrome, all of them develop later as the patient presents. And only 16% present with stage 1 disease. Okay. So, and this is from a 2021 American Cancer Society figures. So that makes the problem at a wider scale. Okay. So if you look at this figure, you can see that the estimated deaths in the United States, as I said, in 2018, now this is the deaths, not the most common cancer. If you look at the most common cancer, we know the most common cancer in female is breast and in male is prostate. But when it comes to cancer deaths, you can see that 25% in both gender cancer deaths is lung and bronchus, or bronchogenic carcinoma. And then if you look at prostate, colon, and pancreas comes next, and combined, all of them are still less than cancer deaths in the lung. Same thing with female. Breast cancer deaths only is 14%. Colon and rectum, 8%, pancreas, 7%. But lung and bronchus by far is 25%. So as I said, if you look over the years, you can see that cancer deaths, and this is among males, lung and bronchus, it peaks in 1990. That's the most common deaths that we've seen. It reaches around 100 per 100,000. And then recently, after that, once we start applying the lung cancer screening, which is we do it for anyone above the age of 50 or between age 50 and 80, and he smoked for 30 years, but he didn't quit, he quit less than 15 years ago. So after that, we can see that the lung and bronchus incidence go down. And most importantly, the incidence goes down because of the decrease in smoking. The decrease in smoking. Once the United States get down smoking from 50% to 15% in the 90s and 2000, we start seeing less in lung and bronchus, although it's still the highest mortality and burden of disease. On the other hand, if you look at the other figures, you can see that for some reason, the liver now cancer and the duct, the biliary tract, the biliary duct cancer is going up. And this is related to many factors, including alcohol consumption and others in the West. Okay, so what are the risk factors usually for lung cancer? As you know, smoking is by far the most common risk factors. 80 to 90% of lung cancer occur in smokers. So if you take lung cancer in general, 90% of these patients are smokers. 10% may be non-smokers, especially female, middle age. And that's what we'll talk later about that brand of cancer, which was the part of adenocarcinoma. Now, if a patient is smoking alone, that's not adequate to develop lung cancer, because 15% of smokers only develop lung cancer. So lung cancer mostly in smokers, but not all smokers develop lung cancer, 15% of them. And a lot of it has to do with genetics. So, and we try to identify a lot of genes responsible for lung cancer, including MUC5B, telomere gene, and others. And other factors, as you know, if a patient is exposed to asbestos, radon, polycyclic hydrocarbons, cadmium, chromium, nickel, arsenic. So those people who work in factories, battery factories, car factories, all these are exposed. If a patient has COPD by itself, other than smoking, COPD is also an independent risk factor for smoking. What does it mean independent? Which means that if a patient has COPD and you have a smoker who has COPD and a smoker who doesn't have COPD, the same characteristics, same age, the patient who has COPD is 5 times more likely to develop lung cancer than the smoker who doesn't have a COPD. That makes sense? So it's important to screen patients who especially have COPD. Aging is a risk factor. Average age of diagnosis is 70. Once you go above that, 80 and 90 years old, you'll see a lot of lung cancer prevalence, even if a patient have remote smoking. So what are the kinds of lung cancer or the classification? As you know, we have two major classifications. We call them either it's non-small cell lung cancer or it's small cell lung cancer. And when you talk about non-small cell lung cancer, you are talking about squamous, you're talking about adenocarcinoma mostly, squamous after that, large cell cancer, and then others, which we'll talk about. Undifferentiated adenocarcinoma, sarcomatoid adenocarcinoma, which has a feature of both adenocarcinoma and sarcoma. In general, non-small cell or small cell. And if you look at the division, the non-small cell is the most prevalent. So around 82% of lung cancer is non-small cell, which is good because the small cell is very aggressive. The small cell lung cancer is at 18%. The non-small cell lung cancer is then divided into adenocarcinoma around 32%, squamous cell carcinoma around 30%, large cell cancer around 9 to 10%, and then undifferentiated 12%. It's important to differentiate these markers because every one of those have distinct genetic markers, especially EGFR, for example, you'll find it in adenocarcinoma. PDL1, you'll find it in adenocarcinoma, you can find it in squamous cell carcinoma. And every one of these mutations, they have different chemotherapy that can work on. And that's why it's important to differentiate. Now, there is a subtype of adenocarcinoma, which is important for you to know, and you may be able to see it in the hospital. We used to call it bronchoalveolar carcinoma, which is around 3%, 3 to 5% of adenocarcinoma of the 30% here comes as bronchoalveolar carcinoma. Now they call it carcinoma in situ. And you will see that cancer, if you screen a smoker patient and you do above age 50 and you look at the CT scan and you see something we call it ground glass nodule, which means that the nodule is ground glass. Ground glass means that you can see the lung behind the nodule. That nodule grows very slowly, and that nodule can be what we call bronchoalveolar carcinoma. And you have to monitor it because it may take years, up to 5 to 7 years for the bronchoalveolar carcinoma to increase. So there's special attention to that bronchoalveolar carcinoma. And the bronchoalveolar carcinoma that I told you about is the one that developed in non-smokers and females. It starts as bronchoalveolar carcinoma, and then after that, you will find it later if it's metastasized or the patient comes in with symptoms. And the good thing about that kind of cancer is that it's 50% responsive to what we call it EGFR mutation medications, EGFR mutation inhibitors. These are the medications that this is the bronchoalveolar carcinoma or the carcinoma in situ now comes in. I want to pay your attention to the bronchoalveolar carcinoma that you have certain subtypes of it as well. You have something we call it mucinous, something we call it non-mucinous, and something we call it lipidic growth pattern, which is when the pathologist look at the cancer after you give him a biopsy, he will tell you if it's mucinous or non-mucinous, and then he will give you if it's lipidic growth. Lipidic growth means it grows beyond septation and lung lines. If one of those cancers can present actually as pneumonia. So the patient will come to you and then it presents late and you look at him and it looks like interstitial pneumonia on the CT scan. And then you treat the patient with antibiotics, with steroids, and he doesn't improve. And it keeps coming back, he doesn't improve. And this patient will tell you, you know, doc, I cough a lot of white salty material. That's why we call it mucinous, because it produces a lot of mucus material, which is salty, and the patient can feel it in his mouth. So be careful. I've seen probably 5 cases last year of the bronchoalveolar carcinoma, which comes in as pneumonia. So if you have a patient with non-resolving pneumonia, make sure that you repeat his CT scan and send him to a pulmonologist for bronchoscopy and biopsies. Okay, so to go further into the presentation and know exactly what are these cancers associated with, as I told you, the most common subtype is the non-small cell, which is squamous and adeno, around 30% each. So that makes it, and then the large cell 9%, so that's 70%, and then small cell is around 18%. So how do they present? And this is important for your boards. They like to ask about paraneoplastic syndromes, right? So the squamous cell, usually, most of the time, it's 95% are smokers. So most cancer in smokers is squamous cell. Now, why it is very important in smokers? Because it develops, it starts in the endobronchial. It develops mostly from the bronchi. And then some patients will complain of hemoptysis. And when you go and do a bronchoscopy in these patients, you will see the cancer inside the bronchus because it's located centrally. It starts in the bronchus and then it located centrally. And that's how it metastasizes. It has only local metastasis. It does not go in too much into the bloodstream and distant metastasis, okay? And this squamous cell type, actually, it's the one that associated with one paraneoplastic syndrome you need to be aware is the hypercalcemia because of the excess secretions of parathyroid-like hormone. So that leads to hypercalcemia. And there's another phenomenon, we call it hypertrophic pulmonary osteoarthropathy. So what happened in these patients, you will see a lot of periosteal reaction around their tibia, around their fingers, around their toes, and they have clubbing of both fingers and toes. And if you do an X-ray, you will see a lot of periosteal expansion. So hypercalcemia and hypertrophic pulmonary osteoarthropathy are both associated with squamous cell. Adenocarcinoma, on the other hand, does not have too much of paraneoplastic syndromes, but adenocarcinoma usually, it's most common in smokers, but if you have a non-smoker that has cancer, it's usually adenocarcinoma, or we talk about bronchoalveolar carcinoma. It's not squamous cell. And mostly it's usually peripheral. It's not central. So that's why when we do the adenocarcinoma, we do bronchoscopy, we have to go peripherally and do more advanced bronchoscopy and the navigation of bronchoscopy to be able to reach that tumor. Now, small cell, on the other hand, it's almost always smokers. It's 18% of cancer, and mostly it's centrally located and it's bulky. If you see a patient with bulky lymph nodes in the mediastinum and the hilar, usually it is a small cell lung cancer. And all the paraneoplastic syndromes, all the other paraneoplastic syndromes are usually developed in small cell lung cancer. And these include, as you know, myasthenia gravis, Lambert-Eaton syndrome, SIADH, right? All those, Cushing syndrome, all those can develop in non-small cell lung cancer. So any paraneoplastic syndrome like Lambert-Eaton syndrome, myasthenia gravis, Cushing syndrome, SIADH, mostly is associated with small cell. So that's for your internal medicine boards, other than hypercalcemia. Any questions so far? Is that obvious?
Yes.
Okay. So it doesn't. I have probably 10 more slides, and then after that we will take practical questions because the questions will take time to solve. So the most important thing that you need to be aware is the lung cancer staging, and you have the lung cancer staging. We used to have something we call 7th edition, and then after that we moved to the 8th edition. And I want to tell you the difference between the 7th edition and the 8th edition in the lung cancer staging. So if you look at and please pay attention here because a lot of my questions will be from this slide, okay? So how to if you have a patient who coming with a lung nodule or with the bulky lung cancer, if it's peripheral, you know, it's probably adenocarcinoma. If it's central, if it's endobronchial, it's squamous cell. If it is bulky and in the mediastinum, then it is small cell. So the cancer staging starts with what we call T and M cancer, as you know. So the T is tumor size, the N is nodal metastasis, and the M is distant metastasis, right? So in lung cancer state, we have 7th edition, and that has been changed to 8th edition. And I'll tell you what are the changes. The most important thing to pay attention here is the T, which is the tumor size, the tumor size. If the tumor is less than 3 centimeters, it's T1. Forget about 1A, 1B, 1C. This is for pulmonologists. So if the tumor is less than 3 centimeters, it is T1. If it's between 3 and 5, it's T2. If it's between 5 and 7, it's T3. If it's more than 7, it's T4. Okay? So let's repeat. So T1, anything below 3. T2, 3 to 5. T3, 5 to 7. And T4, more than 7. Okay? If the tumor, once you do bronchoscopy and you see the tumor is close to the bronchus within 2 centimeters of the bronchus or central, that automatically go into T2. Although the tumor may be 3 centimeters or less, but if it's close to the bronchus or the trachea or the carina, we call it, the version of the trachea, we call it T2 tumor. If the tumor goes into the mediastinum, pleura, we used to call it T4. Now it may be close to M1, which is, we have its metastasis, but they still, in the literature, they still use it as T4. So let's just focus on a T4, which is above more than 70 centimeters, or if it invades the pleura or the chest wall or the pulmonary vessels. So that is, we call it a T4. So this is the T staging, which has to do with the size. Now let's talk about the N staging, which is the lymph node. N0 means no lymph node metastasis. N1, if the lymph node is close to the tumor, it is in the hilum. So if the node that is increased in size is the same in the same plane as the tumor, we call it N1. If it is in the other side, so for example, the tumor is in the left and the lymph node is on the right, that becomes more N3. But if it is in the mediastinal place or subcarinal place, and I'll show you pictures, maybe this is not very clear, then we call it N2, okay? So remember, so tumor size, T1, less than 3, T2, between 3 and 5, T3, 5 to 7, and T4 above 7. Lymph nodes, if it's ipsilateral or hilar lymph node, N1. If it is mediastinal or subcarinal node, it's N2. If it's contralateral, which means on the other side, or super, then we call it N3. Okay? So, and I'll show you how the pictures showed. And then when it comes to M is easy. If there's no distant metastasis, we call it M0. If it's in the pleura, we call it M1 or pericardium. And if it is outside, we call it M1A, M1C. So you don't have to go into details. Just remember, M0 in no distant metastasis, and M1 is A is pleura, and M1B is everywhere else. So this is a summary of the things that I told to you about. So it's the same thing I told you about. So this is T1, T2, T3, T4, if it's above 7, or it goes into the mediastinum or chest wall. Now, I want you to be aware, if the tumor, if you see two nodules, for example, two nodules in the same lobe, that we call it T3. Although the tumor size may be less than 5, to call it T3, it's between 5 and 7 centimeters. But if the tumor is less than that, but you have 2 nodules and you think it's the same tumor, that makes it T3, no matter what the size is. And if there is 2 nodules in different lobes, that makes it T4. Okay, so these are just details, but you may, I don't know if the internal medicine will ask you about. I know the pulmonary board for sure will ask you about. N0, as we said, no lymph node. N1 is if the lymph node is in the same side, and N2 if it's subcarinal lymph node. Subcarinal means it's under the diversion of the trachea, which is, we call it carina. The trachea goes into right and left bronchus. Underneath this, we call it carina. And N3 if it's a contralateral. Now, after you do the TNM, then comes the staging, which makes it more complicated. I don't want you to, focus too much to say that. All I want you to remember at this stage, the most important factor, other than the tumor size, is the node metastasis. Because if you have small tumor, which is T1 or T2, which is below 5 centimeter, right? Small tumor, below 3 or below 5 centimeter, but the lymph node is in the contralateral lung, that makes it stage 3, which is, if you see this column here, can you see my marker?
Yes.
Okay, so if you see this stage here, that's all stage 3. Forget about B, C, it's stage 3. So any N3, which means that the lymph node is in the other side of the lung, that makes it stage 3, okay? No matter what the size is. Now, if the size is small and the lymph node is in the same side, make it stage 2, okay? Stage 2. If the tumor is big, like T3 or T4, and it's only the lymph node is N1, only on the same side, that makes it stage 3 as well. Okay, so stage 1, just remember this, very important. Stage 1 cancer, if the tumor size is small, below 3 centimeter, and there is no lymph node. So below 3 centimeter, no lymph node, that makes it stage 1. And stage 1, you can surgically resect, and the survival is around 70%, 5-year survival. So stage 1, tumor size, T1, less than 3 centimeter, N0, no lymph node, that makes you stage 1. Stage 3, which I talked about, if the tumor size is small or big, but the lymph node is in the contralateral, that makes it stage 3. If it's distant, stage 4, it's obvious. So 1, we talk about 1, we talk about 3. Now 2, if you look at 2, is if the tumor size is between 3 and 5 centimeter, and it's only the same side lymph node is affected. That is stage 2. And stage 2, by the way, can be also resectable. Okay, so you don't have to memorize this table. It's very complicated. I'm going to make it simple. So as I told you, remember stage 1, tumor size small and no lymph node. Stage 3, any tumor size and contralateral lymph node. Stage 2, any tumor size and same side lymph node. So if you have a tumor size of 3 to 5 centimeter and the lymph node is N1, hilar lymph node, then the tumor can be resectable. Tumor can be resectable, remember this. N2 is usually mediastinal or subcarinal. That makes it more advanced tumor. That makes it more advanced. So I made it simple and try to make it simple. Now, how does it come as presentation? Usually, as I said, only around 25% present in stage 1 and 2. And I told you that before, 13% stage 1, 10% stage 2, and then stage 4, usually around 35%. Stage 2, A and 2B is around 45%. So most of the cancer present is stage 2 and stage 3 and higher. 1 and 2 is only 25%. And we talked about this. So most of lung cancer comes in advanced. All right. Now, this classification, the TNM, the tumor size, the node, and the distant metastasis only for non-small cell. Remember, if you want to stage non-small cell, you go TNM. Small cell is different. Small cell, by the way, is it comes from the neuroendocrine glands in the lungs. So it's most of the time it's metastasized before it grows, even if it's very small. That's why they don't go by TNM, they go by, and there's no surgical treatment for small cell. Okay, remember, small cell is only radiation and chemo. And to divide small cell or to stage it, there's limited stage and there's extensive stage. Extensive stage, if the tumor is distant metastasis in the adrenal glands, in the liver, in the bone, usually we call it extensive stage small cell lung cancer or the brain. Limited stage, only 30% of cases, is usually if it's just in the chest or in the lymph nodes on the same side of the chest, or mediastinum. That is called limited stage. So limited stage is mostly for small cell, mostly limited to the lung and the ipsilateral lymph node. Once it goes outside the lung, then extensive stage. And usually, I want you to remember, 18% of smoker, 18% of lung cancer is small cell. If you see brain metastasis from a lung cancer, most of the time it's small cell. That's why we do prophylactic brain radiation in patients who have advanced small cell lung cancer. We do not do that in non-small cell unless the patient have neurological symptoms, So always look in the brain for small cell. Now, this is physiology. You will enjoy because it has a lot of math and calculation. And I want you to learn this because it's very important for you as a medicine resident. I know, you have some exposure to pulmonary, but same as here in the United States, the internal medicine residents, they do not have too much exposure to pulmonary, unfortunately, for different reasons. Because, too much, we're busy in the ICU with the COVID makes things complicated, but that's why it's very important to remember these for internal medicine residents and know how to approach patients with lung cancer, okay? So this is, we call it preoperative assessment, which means that is your patient a surgical candidate? Once you stage lung cancer, this is your second question. When should I refer to the cardiothoracic surgeon to resect that tumor? You need to remember. So the first thing you did the staging, you did TNM, you classify the patient, he's stage 1 or 2, 2A or 2B, then it's resectable. We should resect it. Now, is the patient a candidate for resection? Then we go into physiology and pulmonary function test. And this is what I want to talk in the next 2 slides. So, in general, if a patient's going for pneumonectomy, so stage 1 or 2, but the tumor is centrally located and the lymph node is in the hilum and it goes above, for example, covers both the upper lobe and the lower lobe. So you decide you want the patient to have a pneumonectomy, not a lobectomy. When is it safe to do a pneumonectomy? If the FEV1 is more than 2 liters, which is when you do a lung function, the forced expiratory volume capacity is more than 2 liters. If you want to do a lobectomy, you want the FEV1 to be at least 1.5 liters. But this is very rough assessment. This is in general. Now, to go into more details, you want the FEV1 above 60% of predicted. 60% of predicted. What's the normal FEV1 in normal individuals?
More than 80.
No, FEV1. You're talking about peak expiratory flow rate. The FEV1 is 3.5 liters. What's the FVC, the forced vital capacity? 5 liters. I'm going to physiology now. So the forced vital capacity, 5 liters, the FEV1 is 3.5 liters. So if you want 60% of predicted, that is approximately around 1.8 to 2 liters. Anything below that increase the risk of respiratory complication. Now, The DLCO, which is the diffusion capacity for carbon monoxide, which we measure by making the patient inhale carbon monoxide, and then we'll see what's the diffusion of the carbon monoxide. We measure the air that comes out from the patient, and we divide it by the air that comes in, and we calculate the DLCO. The DLCO measures the bulk of the alveoli. You want that to be also above 60%, okay? So remember, you want FEV1 above 60%, and you want DLCO above 60% of predicted for the patients, okay? Anything above, below that will lead to complications. Now, let's go beyond that. Do you guys have any questions here? Is it clear?
Yes.
All right, so let's go beyond that. So this is, we call it pre-operative assessment, which means that you do every patient that's going for lung resection, he needs pulmonary function test. You do pulmonary function test, and you see the FEV1 and the DLCO is above 60%, that makes me happy. Then the patient is probably a candidate for lung resection, okay? Now, to know, they will ask you, what is the risk of complications after procedure? What you're gonna tell them, you will tell them, I need to know what is the predicted lung function after procedure. And we can calculate this very easy. I'll tell you how to calculate. So before surgery, you want FEV1 and DLCO about 60%. Now, after surgery, the FEV1 and DLCO, of course, they will both be decreased because you took part of the lung away, right? What do you want the DLCO and FEV1 after surgery? The predicted, you want them above 40%, both FEV1 and DLCO. You want them above 40%. So how do you calculate how many, what percentage? So we do something, we call it perfusion scan. Perfusion scan give you how much blood and air go to each lobe. But in general, as pulmonologists, you know that the largest lobe of the lung usually is the right lower lobe because it has 5 subsegments, okay? So the right lower lobe, we give it around 5 times. The right, yeah, the right middle lobe, it has only 2 lobes or 2 segments, medial and lateral. So that's around 20, 25 and 20%. And the right upper lobe is 30%. So I'll give you an example. So if the right lower lobe is 50%, without doing a diffusion scan, because I don't think we can do a diffusion scan in Palestine. But so if the right lower lobe is 50%, okay, and the patient FEV1 is before surgery, it was 70%. So you're good. You tell him, it's about 60%. I'm okay with you doing the procedure. And the surgeon wants to take the right lower lobe out. So that 50% of the right lung, 50% of the right lung. But the left lung is still there, and the right upper and middle lobe are still there. So 50% of that's around 25% of the total value. So if the patient FEV1 is 70% and you want to take 25% of it away, which is, ruba, one fourth or 1/4. So 70% divided by 1 or times 1/4, and you're talking about 15 to 17% is going to go away, right? So what's left for the patient is going to be around 70% minus 15% is around 45%. So the patient, or 55%. So the patient is good to have surgery because both the FEV1 and the DLCO are above 40% predicted after surgery. Is that clear? So before surgery, you want the FEV1 and DLCO to be above 60%. After surgery, you want both to be above 40%. And you need to do calculation, depend on which part of the lung are you taking out and what is the percentage of that lobe for the total lung function. I'll make it that very simple. So then you go into whether it's clear or not. Okay, after that you go into your clear or not. So, I don't want to make it complicated. So again, this is the PPO is post-operative, which is what you predict the FEV1 and DLCO to be. If the post-operative FEV1 and DLCO, I said above, you want it above 40%, then you're okay for the patient to go to surgery, okay? If both of them, the post-operative predicted is above 60%, like the pre-operative predicted, then the patient is low risk here. If the post-operative predicted is between 30 and 60%, then you have to do additional testing. We call it exercise testing, okay? And then based on the exercise testing, then the patient can be moderate or low risk. If the DLCO or the FEV1 post-operative predicted less than 30%, then the patient is high risk, okay? So as I said, this is the same thing. If the patient have FEV1 or DLCO above 60% pre-operative and predicted post-operative is above 60%, then you're good. So you want 60% for both pre-operative and post-operative, then you are good. If the post-operative between 30 and 60%, then you have to do an exercise testing. If it's between 30 and 60, you have to do exercise testing. If it's less than 30, then it's high risk. You said no surgery. The patient needs to go to chemo and radiation treatment. Do you have question about this slide?
If we did an FEV1 and DLCO for a group of patients, and all those patients have an FEV1 DLCO above 60, can we predict whom of these patients these FEV1 DLCO will decrease below 60 after the operation?
That's correct. If it's 60% before operation and you want to take a lobe out, correct. The FEV, if it's 60%, the FEV1 and DLCO will be less post-operative. Depend on which lobe you are taking out. If you are taking like 25%, خلينا نحكي ربع اللنج. انت اخذت ربع الرايت لانج. هلا اللنج انت بتعرف الليفت لانج ما هي 2 only 2 lobes upper و lower فيش middle صح؟ bilingular. فانت عندك upper و lower معناته الليفت لانج حوالي 45% من التوتال والرايت لانج حوالي 55%. اوكي؟ انا بدي اعطيك اياها رفلي. الليفت لانج 45%، الرايت لانج 55%. معناته اذا بدك تاخذ نص الليفت لانج معناته انت اخذت نص ال 45%، يعني 23% من التوتال صح؟ معناته اذا الاف اي في 1 عندك 60% بلشت بدك تنقص منه 23% من 23% من ال 60%، يعني بيطلع حوالي 10، يعني بيطلع حوالي 45%. معناته حكيك صحيح. معناته اذا بلش 60% معناته بوست اوبراتيف اللي راح يصير 45%. معناته في انو كاتيجوري هو؟ في الكاتيجوري اللي هي هاي اللي انا حاطط عليها السيركل. الدي ال سي او والاف اي في 1 اقل من 60 بس اكثر من 30 اللي هو حوالي 45%. معناته هل بتقدر انت تحكي انه البيشنت لو ريسك؟ لا، بدك تعمل له اكسرسايز تيستينج، واذا في الاكسرسايز تيستينج مشى اكثر من 400 متر معناته هيز لو ريسك. اذا ما قدرش يمشي 400 متر معناته هو هاي ريسك. اوكي واضح؟ معناته هاي هي. هلا اذا if you calculate اذا واحد كان بلش اف اي في 1 90% وبدك تاخذ الليفت ابر لوب 25% من التوتال معناته بنزل ل 65%، معناته هي سيف بيقدر يروح على السيرجري. هي هيك الكاتيجوري. اذا بيشنت بلش 40% وبدك تاخذ 25% من 40% راح يصير تحت ال 30 معناته he's not safe to do surgery. So this is rough. This is how we do the معناته this is simple. I will ask you questions about this. So remember the one I circled. طيب ضايلنا هلا حوالي ربع ساعه، بعرفش قديش معكم وقت. ربع ساعه انا وراح نبلش اسئله. اوكي هلا السوليتري pulmonary nodule important very important. عندك benign. ايش هي البناين فيتشر وايش هي البناين نوديول؟ ممكن يكون بناين ممكن يكون مالجنت. شو البناين نوديول؟ اللي هي مثلا عندك جرانيولوماز، عندك مثلا انفكشن، عندنا هون احنا في اوهايو في كثير فانجل انفكشن، عندك بناين نيوبلاست such as hamartoma واذرز ويجنر روماتويد نوديول، هدول كلهم بناين. المالجنت نوديول 50% منها ادينو، 20% منها سكويماس، وسمول سيل فيري ريرلي تكون solitary nodule but most النوديول malignant بتكون cancer. هلا how to differentiate between المalignant وال benign pulmonary nodule؟ اللي بدك تعرفه في شيء اسمه you have to calculate pretest probability لأنه إذا ال pretest probability كان low بدك تعمل CT scan 3 months 6 months 1 year. I will tell you how to differentiate. If it's intermediate probability من 50 60% بدك تعمل biopsy. If it's above 50 60% لازم تعمل excision. وهاي هي الكالكوليشن موجوده على اونلاين. انت اذا شفت اي مريض عندك نوديول في العياده تفتح على طول على شيء اسمه مايو كلينيك، من مايو كلينيك هي هوسبيتال في مينيسوتا، لون كانسر سكور ريسك سكور، والسكور بعطيك بحكي لك قديش البيشنت ايج. اذا البيشنت ايج above 70 معناته هذا هاي ريسك. بحكي لك على السايز تاعت النوديول، any nodule above 8 mm high risk. If the patient still smoking بعطيك 1 point. إذا في عنده history of cancer outside the lung 1 point. إذا النوديول is upper lobe high risk بعطيك 1 point، وإذا speckled بعطيك 1 point. Okay. So هاي الريسك فاكتور كالكوليتر. وبعدين راح أحكي لك على lung nodule. So if you see here the lung nodule طلع على أي nodule above 8 mm. remember النمبر 8 ملم يعني 0.8 سنتي، يعني تقريبا 1 سنتي. اذا 8 ملم وابove بدك تعمل سي تي سكان، لازم تاخذ الشغله سيريس، وبدك تعمل سي تي سكان لانه 25% من هدول النوديول بيكونوا مالجنانت especially in high risk patients. معناته بتعمل الكالكوليشنز، الكالكوليشن طلع عالي بدك تعيد السي تي سكان خلال 3 months او انه تكونسيدر انه تعملها بايوبسي. فاذا ال 8 ملم هي الحد تبعك، لازم تعمل سي تي سكان خلال 3 months. اذا كانت 6 to 8 اقل من 6 باي ذا واي هلا بطلوا يعملوها فلور. 6 ل 8 ممكن تعمل ريبيت سي تي سكان خلال سنه. اوكي خلال سنه. هاي ان جنرال. هلا هاي للسوليد نوديول. في عندك نوديول which can be sub-solid أو ground glass. هدول النوديولز أقل يعني أقل ريسك فاكتور. إذا كانت عندك ground glass معناته زي ما حكيت هاي ممكن تكون كارسينوما إن سايتو، معناته ممكن تسوي السي تي سكان خلال 6 to 12 months إذا كانت about 6 ملم. طيب هلا اللون كانسر سكرينينج بسرعه بدي احكي على اللون كانسر سكرينينج، مش رح اطول. اللون كانسر سكرينينج as you know الترايل اجت في النيو انجلاند جورنال in 2011، والترايل حكت انه they study حوالي 53,000 patients. اوكي و they found out انه 25% من البيشنت من هدول ال 50,000 شافوا نوديول وطلع بوزيتيفلي سكرين تبعهم. they compare them للchest x-ray. عملوا annual CT for 3 years وعملوا chest x-ray for 3 years، ولاقوا انه لما تعمل السي تي 25% ممكن تلاقي lung cancer، في حين في الاكس راي only 7%. فاستنتجوا انه 20% reduction in mortality by doing the annual lung cancer screening. هلا البروبلم with the lung cancer screening انه معظم الاحيان بتشوف nodules which is معظمها non malignant. شايف؟ فهذا بيؤدي الى كثير resources consumption وتكاليف، وبدك البيشنت بخاف وبصير بده سي تي سكان كل 3 اشهر، فمشكله رايت. فعشان هيك بيحكوا لك to minimize الفولس بوزيتيف في اللون كانسر سكرينينج لازم تعمل سي تي سكان فوليوم سي تي سكان، شيء اسمه doubling time, which means that you have to decide إذا التيومر is growing or not. اوكي هذا هو يعني الكونسومشن. واجوا الراديولوجي حطوا characteristics مختلفه كليا اسمها long grads، وحكوا based on the long grads system الراديولوجيست راح ينسالوا عنه، انه بحكي لك السيستم هو كاتيجوري 1 2 3 or 4. 4 يعني high risk category for lung cancer، 1 is low risk category. فكيف بحكي لك low risk category؟ اعتمدوا على السايز of the nodule، اعتمدوا على السايز. اذا النوديول سايز زي ما حكيت انا above 6 to 8 معناته usually it's higher category around 2 category 2 to 3. if it is above 15 millimeter يعني 1.5 سنتيمتر او ground glass above 3 سنتيمتر يعني بدك huge ground glass، هاي بتصير category 4. اوكي سو هذا الكاتيجوريز اللي هو to decrease الفولس بوزيتيف، وهذا اللي هلا احنا بنمشي عليه. فهلا شو الريكومنديشن يا جماعه؟ الريكومنديشن any patient remember this very well please between age 55 and 80 we smoke more than 30 pack year وهي quit خلال 15 سنه، يعني مش اكثر. اذا اكثر من 15 سنه quitting معناته الريسك اوف لانج كانسر بتقل. فاذا عندك patient between age 55 and 80 وسموكينج history more than 30 pack، التشست فيزيشن احنا البولمونولوجيست حكوا ليتس خليها 20 باك 20 باك عشان نكتشف اكثر. 20 to 30 باك خليني احكي لكم اياها، معناته بدك تعمل له لانج كانسر سكرينينج وكل سنه بتعمل له اياها لمده 3 سنين. اذا شفت نوديول طبعا بدك تفولو الجايد لاينز تاعت النوديول اللي حكيت عليه. اوكي طيب خلينا ناخذ كويستشنز هلا لانه هيك صارت بورينج، فخلينا ناخذ كويستشنز. فانا بدي امشي هلا على الكويستشنز. طبعا الكويستشنز ار فيري كراودد، هاي على فكره من البولمونري بورد ريفيو الليكتشر والكويستشنز. فخلينا ناخذ كويستشنز. اوكي معكم 10 minutes everyone 10 minutes.
اوكي دكتور
تمام معناته خلينا نحكي. طيب عندك 57-year-old male active smoker and you find a lung nodule. Okay, the lung nodule showed speculated lung nodule اللي هي 15 times 11 millimeter يعني 1.5 centimeter. Okay, it's non-calcified and it's in the upper lobe. He's without any cardiopulmonary symptoms. He's still smoking 1 pack per day for 40 years. He lives in a region endemic for fungus اللي هو histoplasmosis. عندنا في اوهايو في fungus. وعنده الفاميلي هيستوري include cancer in the mother و COPD. اوكي هلا عملت انت البري تيست probability اللي هو المايو كالكوليشن فرجيتكم اياه، طلع 50%. تمام 50%. هلا السؤال، هاي السي تي سكان، شايفين السي تي سكان؟ تمام اوكي السؤال which of the following is true؟ وبدي اياكم انتم تجاوبون. A negative PET scan has high enough negative predictive value في هاي الحالة انك تحكي خلاص يعني بلزمش انه نعمل بايوبسي والبيشنت هذا بدنا نعمل له سيرفيلانس سيريا سي تي سكان. هاي واحدة. تنتين بدك تعطيه انتي بايوتيك وتريبيت السي تي سكان. 3 بدك تعمل له اليل بدك تعمل له النافيجيشن برونكوسكوبي بيحكي لك اليل تبعها 80%. بحكي لكم غلط، النافيجيشن برونكوسكوبي هذا برونكوسكوبي بروح للبريفري يوجوالي اليل تبعه 60%، فهي غلط. رقم 3. رقم 4 management option if it's imaging if it's low probability for cancer which is less than 10% هو هذا high probability. بدك PET scan or biopsy إذا البروبابيلتي 10 ل 70% زي البيشنت تبعنا، أو surgical resection is above 70%. فأني واحدة من هدول 1 2 3 4 إيش الصح؟ نعم؟
يعني 1 and 4 يعني
1 and 4
1 and 4 يعني
مظبوط ممتاز. 4 الصح على فكرة، 1 غلط. في هاي الحالة يا جماعة إذا البيت سكان is negative I will not believe it. okay لأنه it's a high risk. البيشنت عنده 50% risk of cancer. حتى لو البيت سكان is negative، حتى لو PET scan is negative, this probably it's a false negative. Okay, so in this case, a negative PET scan does not have a high negative predictive value. يعني إذا كانت negative, you still need to biopsy this patient. فit's 4 الcorrect اللي هو what I would do in this case. I would do either a PET scan بس إذا negative راح أعمل biopsy. but إذا positive بيساعدني إنه خلاص this is cancer، أو إنك تعمل له bronchoscopy، أو إنك تعمل surgical resection إذا كان high.
Okay, when can we rely on PET scan to evaluate?
Always
Like,
rely on the PET scan. بس البيت سكان عادة إذا النوديول less than 1 centimeter it become less specific. يعني ممكن تكون negative. هلا هاي النوديول كبيرة تقريبا 1.5 centimeter، فهي it's gonna be PET positive most likely. بس اللي بحكي لك إياه السؤال إذا البيت سكان negative ما يعني مش تحكي إنه خلاص هاي this is not cancer. This is what they mean. بس أنت دائما اعتمد على البيت سكان. بس اتذكر إنه إذا أقل من سنتي النوديول أو الليمف نود عادة إحنا بنعمل برونكوسكوبي وبنعمل اندوبرونكيال الترا ساوند، يعني ندخل على الليمف نود عن طريق البرونكس وبعدين الترا ساوند. حتى لو البيت نيجاتيف نعمل شيء اسمه ستيجنج لللون كانسر، لانه كثير بنشوف حالات بيت نيجاتيف ليمف نود لانها اقل من سنتي البيت سكان ما بتشوفها. اوكي ريمبر كمان امتى البيت سكان بتشوفش؟ الجراوند جلاس البيت سكان ما بتشوفها منيح، الليمفوما واللوكيميا البيت سكان ما بتشوفها منيح. فيو هاف تو ريمبر في بعض شو اسمه كان نوت بي بيت كان بي بيت نيجاتيف. طيب question 2. Okay, pay attention to this. 73-year-old former smoker. عنده left lower lobe mass 5.5 سنتيمتر. تمام؟ هلا صار عنده respiratory infection، عملت له هذا شفت انه 5.5 سنتيمتر في left lower lobe. عملت له برونكوسكوبي وعملت له اندوبرونكيال التراساوند ستيجنج وشفت انه الماس موجوده في في عنده involvement of the subcarinal lymph node subcarinal. فانت عندك 5.5 سنتيمتر ماس في الليفت لور لوب وعندك subcarinal node. السبكراينال نود ايش بتصير؟ N2. تذكروا الهايلر اللي هي N1 subcarinal N2. تمام. عنده عملت له بيت سكان والبيت سكان شو انه عنده انه شود انه ليفت لور لونج ماس وشود السبكراين. تمام؟ اوكي. البرين ايمجينج عملت له سي تي سكان برين نيجاتيف. تمام. Based on this, the 8th edition, which stage is the patient? بدي اياكم هلا واحد يحكي لي شو الستيج.
T3 N2.
T3
N2.
N2
M0.
M0 معناته ايش الصح؟ الرابعة. ممتاز. تمام. هيك صرتوا انتو اكسبرت. تمام. السؤال الثالث ضايل بس سؤالين عشان اخلص انا بعرف عندكم شغل. طيب 68-year-old male عنده cough وسبيوتم برودكشن وعنده هيموبتيسيس. تمام. عملت له سي تي سكان شفت انه رايت ابر لوب في 7.5 سنتيمتر ماس والماس حوالين الرايت ابر لوب برونكاس بس didn't reach المين برونكاس. اوكي. وما عملتش اتيلاكتسيس وما فيش ادينوباثي. there is no mediastinal adenopathy. عملت له بيت سكان وعملت له برونكوسكوبي واندوبرونكيال الترا ساوند وعملت ستيجنج للهايلم والميدياستاينم وعملت برين MRI everything came back negative. الكانسر طلع سكويموس سيل وما في نود ليمف نود وما في برين ميتاستاسيس. شو الستيج تبع الكانسر؟
T4 N0 M0 4
ستيج 3A. ممتاز. تمام. دي يعني T4 N0 M0. تمام. سؤال بعده ايش هو؟
اوكي حكيت معك.
يلا اخر ضايل سؤالين. طيب عندك 52 52 year old active smoker 40 pack year. عندها cough و shortness of breath و wheezing، أعطيتها antibiotic و steroids did not improve. عملت لها سي تي سكان شفت 4.5 طيب 5 سنتيمتر speculated mass في الرايت upper lobe، هيك شايف البيت سكان تمام. والهاي الماس it's involving المين pulmonary artery. otherwise the patient is healthy وما عندوش أي other symptoms. عملت بيت سكان وعملت برونكوسكوبي وعملت endobronchial ultrasound وعملت MRI of the brain. طلع عندك إنه اللون كانسر هي أدينوكارسينوما وما فيش distant spread. هلا أنت قررت في الحالة إنك تعمل نومينكتومي صح؟ ليش؟ لأنه الناس طلع عليها ماخذه البولمونري ارتري وماخذه الهايلاند، بدك تعمل له بدك تشيل كل اللون تمام الرايت لون. عملت له بولمونري فانكشن تيست طلع عندك الاف اي في 1 2 لتر 78% اوف بريدكتد. الديفيوجن كاباسيتي طلع 69% اوف بريدكتد. عملت برفيوجن سكان اوكي، احنا ما عندنا برفيوجن سكان بس هون احنا بنعمل برفيوجن سكان. عملت برفيوجن سكان، انا علمتكم كيف تعملوا ابروكسيمات، حكيت لكم اللور لوب 25% الابر لوب كله هذا ابروكسيمات، بس برفيوجن سكان هي اللي بتفرجيك شو الصح. البرفيوجن سكان اعطتك انه 50% برفيوجن للرايت لانج 50% او 49%، 5% في الابر لوب و44% في اللور لوب البرفيوجن، معناته الرايت لانج 50%. تمام تمام. Which of the following statement about the risk of pulmonary complication from a right pneumonectomy is most correct? شو رايك؟
شيل الرايت ابر لوب صح؟ لانه الماس في الرايت ابر لوب.
الماس في الرايت ابر لوب بس ماخذ البولمونري ارتري. فبدك تعمل هاي صارت اذا ماخذ البولمونري ارتري صارت تي 4. بدك تعملها بدك تشيل اللي فيش ليمف نود ميتاستاسيس، بس عندك سيرجيكالي لازم تشيل اللنج كلها. السؤال بحكي لك هل البيشنت is طلع is low risk, high risk or moderate risk or I don't know. I need more testing. So تذكر الالجوريثم، تذكرين الالجوريثم اللي فرجيتكم اياه اللي هو البوست اوبراتيف FEV1 و DLCO. So calculate the post-operative FEV1 و DLCO هون. قديش البري اوبراتيف FEV1؟
78.
78 وانت بدك تاخذ الرايت لانج كلها. قديش البرفيوجن تبع الرايت لانج؟ قديش؟ 50% 49% صح؟
28 هاي ريسك حكينا.
ايوه لا لحظه 78% من الاف اي في 1 بدك تاخذ نصها، بدك تشيل 50% من 78%، قديش بضل؟
70 قسم على 2
25 يعني
قسم على 2 حوالي 40 او 39% خلينا نحكي تمام. طيب هذا الاف اي في 1 والدي ال سي او 70% بريدكتد، قسم على 2 قديش الدي ال سي او بضل؟ 35%. معناته اذا الاف اي في 1 والدي ال سي او البوست اوبراتيف اذا اقل من 30% زي ما حكيت انت هاي ريسك ممنوع سيرجري، بس اذا بين 30 و60 شو بدنا نسوي؟
تيستينج حكينا، بدك تعمل مودريت ريسك تيست،
بدك تعمل 6 minute walk test او اكسرسايز تيستينج. معناته شو الجواب الصح هون؟
بي need more testing. Additional testing required D.
Exactly. Additional testing is required. لأنه أنت ما بتعرف إذا شو اسمه. طيب. أوكي. خلينا نشوف هذا السؤال. طيب هذا السؤال بيحكي عن اللونج جرادز. أنا ما حكيت لكم مش كثير عن اللونج جرادز. فبلاش نحكي عن اللونج جرادز هذا. ناخذ هذا السؤال. أوكي يلا آخر سؤال. طيب عندك 67 year old 40 pack year smoker عنده polycythemia on lab work. عملت له chest imaging. الchest imaging شاف 1.5 cm speculated nodule في الرايت upper lobe. هيكم شايفينها، شايفين كيف speculated و 1.5 cm معناته هاي high risk. هاي ريسك اتليست 50% ريسك اوف كانسر. طيب عملت له معناته بيت سكان، البيت سكان طلع بوزيتيف 7.8 ابتيك اس يو في، معناته ايش؟ عندك لازم تروح على بايوبسي، عملت له بايوبسي، البايوبسي طلع ادينو كارسينوما. هلا وين المشكله؟ كملت انت لقيت انه في كمان سمول نوديول في فيجر 2، شايفها على البريفري، هاي سمول، هاي هون موجوده وين؟ في البريفري اوف ذا which لوب؟ في الرايت لور لوب. هلا الماس في الرايت ابر لوب والنوديول في الرايت لور لوب. تمام؟ طيب معناته ايش بتصير هاي؟ تي 4 مظبوط. هلا لو موجوده في الرايت ابر لوب هاي النوديول ايش بيكون؟
تي 4 بالضبط
مش ستيج، تي 3 بتصير. تي انت بتحكي عن تي، هلا بتحكيش ستيجنج، بدك تحكي تي ان ام وبعدين تحكي شو الستيج. فهاي تي اذا عندك اذا تو نوديولز ان ذا سيم سايد بتصير ان ذا سيم لوب بتصير تي 3، اذا ديفرنت لوب بتصير تي 4. اوكي طيب السؤال الثاني هلا بحكيها. طيب كارديوبولمونري اسسمنت ريفيلد مودريت ريسك اذا عملت لوبكتومي، فعملوا ويدج ريسكشن اوف ذا رايت ابيكس وعملوا السمول رايت لور لوب نوديول برضه عملوا لها ويدج ريسكشن، والتنين بينوا انه ادينو كارسينوما والليمف نودز نيجاتيف. تمام؟ السؤال which stage is the cancer؟ A, B, C or D؟
T4N0 M0.
Excellent. Stage 3A صحيح. T4N0 M0 stage 3A. So that's C. تمام. طيب هلا okay that's it. I think هذا the last questions. عندكم any questions؟
دكتور if the nodule in the contralateral lung M1.
M1. M1. M1 هلا لانه بيكون distant metastasis. هلا شو المشكله؟ بديش اعقدكم انا بس مرات بيطلعوا two different cancers ولازم تعملهم staging كل واحد على حده. هلا كيف بتميز من الجينيتك تيستينج؟ اذا الجينيتك تيستينج تبع الكانسر نفسه معناته بيكون نفس الكانسر، اذا different mutations معناته بيختلفوا.
Doctor, question. We depend not only on FEV1 and DLCOs on for pneumonectomy or lobectomy for lung cancer. Vocal cord paralysis and something like this. Is Horner syndrome a contraindication to do?
Yeah, because this is distant metastasis بصير. البانكوس تيومر اللي بيسبب هورنر سيندروم بيكون عنده involvement في البلورا والريكرنت لارنجيال نيرف. فهذا بيكون عادة T4 كانسر T4. وإذا ما عنده N1 M0 إذا ما كان عنده ليمف نود يعني at least stage 3 to 4 بيكون T4 كانسر. فإذا T4 هذا ما يعني it's not usually stage 3 or 4 it's not resectable. We don't do surgery section. فالبانكوست mostly التريتمنت تبعه بيكون كيمو راديشن لأنه T4 involve البارينكيما involve الchest wall والبارينكيما والريكرنت لارنجيال نيرف. طيب تمام يلا يعطيكم العافية، وإذا عندكم أي question email me please.
Okay, very much. شكرا دكتور.
يعطيكم العافية، مع السلامة.